You will hear a conversation between a respiratory nurse specialist and a patient, Mr. David Chen, during a review of his asthma action plan. Now you have 30 seconds to look at the notes.
Good morning, Mr. Chen. Thanks for coming in today. We're going to spend a little time just going over your current asthma control and your action plan, making sure everything is working as well as it can be. First things first, how long has it been since your last hospital admission for asthma?
Good morning. It was quite a while ago now. I'm relieved about that. It was about 8 months ago, I think. Time really flies.
That is genuinely encouraging news, Mr. Chen. We always aim to keep you out of the hospital, so that suggests we're doing something right. Now, let's dig into the day-to-day. On average, how often are you experiencing those troublesome symptoms like coughing, shortness of breath, or wheezing during a typical week?
It's roughly 4 times a week, which feels like a lot to me, honestly. Sometimes it's more if the weather changes drastically. That cold air really hits me.
I understand. Having symptoms that frequently can really impact your quality of life. And does it wake you up at night? Sleep is so important for everyone.
Yes, it does sometimes, which is the worst. Maybe once or twice a month, I'll wake up wheezing and feel that panic, and I immediately reach for my blue inhaler. It's disruptive.
That's valuable information. Waking up at night is a key indicator that we need to tighten up your control. Can you try to put into words how you would describe the feeling in your chest when your asthma is playing up? Is it tight, scratchy, like a cough?
More than just the wheezing, which is obvious, I have this constant heavy feeling in my chest, especially in the evenings. It's not painful, but it feels like I can't fully expand my lungs, you know?
I know exactly what you mean. That heavy or tight feeling is classic. We've talked about triggers before, but is there anything specific you've noticed that almost always sets off your symptoms?
I'm almost certain it's the dust mites. Every single time I clean or change the bedding or even just dust the house, I feel noticeably worse a few hours later. I think I need to look into better bedding protection.
That is a very common trigger. We can certainly talk about some practical ways to manage that. Now, let's pivot to your medication. It's vital we check your consistency with your brown controller inhaler. Are you taking it reliably?
Oh, absolutely. I take it twice daily, morning and evening, like clockwork. I never miss that because I know how important it is for keeping the inflammation down.
That's excellent adherence, Mr. Chen. Well done. Now, let's talk about the blue reliever inhaler. How often are you finding you need to use that rescue medication throughout the day? Be honest.
On average, probably 3 or 4 times a day, maybe 6 on a really bad day if I've been active or around dust.
Thank you for being so honest. That's significantly more than recommended, which immediately tells us your asthma control is not as optimal as we would like it to be. If you're using your reliever more than twice a week, outside of pre-exercise, it suggests your preventer isn't doing enough heavy lifting. Let's check your technique on that controller inhaler again. Just a quick demonstration for me, please. Ah, I see a small but important detail. You're rushing the inhalation phase. You need to breathe in slower and deeper, and then hold your breath for a count of 10. That gets the medication to where it needs to go.
Okay, I think I was trying to breathe in too quickly, and I have one little worry about that brown inhaler. I've read about it, and I'm concerned it can cause thrush in my mouth. Is that a real risk?
That's a perfectly valid concern, and yes, it can happen because the steroid settles in your mouth and throat. To help prevent that, You must rinse your mouth thoroughly and spit out the water immediately after every use. But even more importantly today, we need to introduce a spacer device with the controller inhaler. It will significantly improve the delivery of the medicine into your lungs and drastically reduce the amount of residue left in your mouth, which cuts the thrush risk right down.
A spacer device, okay. I'll make sure to start using that straight away.
Fantastic! That's a great first step. Over the next week, I want you to start monitoring your peak flow daily, once in the morning and once in the evening, and record the readings on this chart. That will give us objective numerical data on your actual lung function, not just how you feel, so we can adjust your medication dosage accurately next time.
That makes sense. Numbers don't lie.
Exactly. And finally, the most critical part. We are revising your written action plan today. This is what you do if you feel a definite acute attack starting. You are now advised to take 4 to 6 puffs of the reliever inhaler, making sure to wait a full 60 seconds between each puff. If there's no improvement after about 10 minutes, you must call for medical help.
Got it. Slow breathing with the brown one, spacer, mouth rinse, daily peak flow, and 4 to 6 puffs on the blue one during an attack. Thank you. I feel much clearer about what I need to do now.
You're very welcome, Mr. Chen. We'll schedule a follow-up in 4 weeks to review that peak flow data. Would you like me to find you some information sheets on managing dust mites in the bedroom?
Extract 2. You will hear a conversation between a general practitioner, GP, and a patient, Mr. George Wallace, regarding new onset facial pain. Now you have 30 seconds to look at the notes.
Good morning, Mr. Wallace. Please come in. I've been reading your referral notes. It seems you're here about some severe facial pain. Your previous GP suspects it might be trigeminal neuralgia?
Morning, doctor. Yes, that's what he mentioned. It's agonizing. Significant doesn't quite cover it.
I can only imagine. Can you tell me about it from the beginning? When did it start?
Let's see. It started just after my wife's birthday, so must be about, 4 weeks now.
And can you be precise about the location? Does it match the typical pattern for this condition?
Yes, it's exclusively on the right side of my face. My left side is completely fine, not a twinge. It seems to shoot from near my ear, right down along the jawline.
And the character of the pain. Is it a dull ache or...
No, nothing like that. It's not a headache or a typical toothache. It's a sudden jolt, like a bolt of lightning. The only way I can describe it is like a sharp electrical shock. It just fires without any warning.
And these attacks, how long do they last?
Oh, it's not hours. The worst part, the shock itself is incredibly brief. I'd say a few seconds at most, but then it can happen again and again in a sort of cluster for a minute or two.
I see. And what about the time in between?
That's the strange thing. In between the attacks, I'm completely fine. No pain, no residual ache. It's 1 minute I'm normal, the next I'm on the floor, but I am totally pain-free between episodes.
That pattern, the location, quality, and pain-free intervals, cements the diagnosis for me. What seems to trigger these attacks? Is it spontaneous, or are there specific actions?
It can be spontaneous, but there are definite triggers. A cold breeze on my face can do it, but the most reliable one, the one I absolutely dread, is brushing my teeth. As soon as the brush touches that side, it's instantaneous.
That's another classic sign. Have you tried any medication to manage it so far?
At first, I was convinced it was an abscess, so I was taking paracetamol, ibuprofen, just the standard painkillers. I was taking the maximum dose, and they did absolutely nothing. Didn't touch it.
That's to be expected, I'm afraid. And has this affected your daily life in other ways? Eating, drinking?
Well, yes, I'm quite anxious about it, as you can imagine, and I've lost a bit of weight because I'm frankly reluctant to chew solid food. The movement of the jaw, it can set it off. I've been sticking to soups.
That's very common. As this is nerve pain, standard analgesia won't work. We need a medication that targets nerve activity. The first-line treatment is an anticonvulsant. I'm starting you on carbamazepine.
An anticonvulsant. Okay.
Now, with this medication, we need to monitor for side effects. You might feel some initial drowsiness, but the main thing I need you to be vigilant about is any dizziness or unsteadiness. If you feel wobbly on your feet, you must call the practice immediately.
Dizziness. Right. I'll watch for that. What's the next step?
Good. This usually manages the symptoms well. But as a precaution and to manage this long term, I'm also arranging an MRI scan, and I'll make a specialist referral to a neurosurgeon. They are the team that handles the definitive long-term management if the medication becomes less effective over time. But for now, let's get you started on this prescription.
Question 25. You hear a senior nurse briefing staff about the new protocol for preparing patients for surgical theater. Now read the question.
Team, the primary issue we faced last month wasn't the consent forms, those were all checked. It was the late discovery of minor dental work, crowns and bridges, that weren't correctly documented during the initial check, forcing last-minute anesthesia changes. So, the updated protocol prioritizes the pre-anesthetic review. While ensuring the patient is correctly gowned and jewelry is removed is routine, the mandatory check now requires a verbal confirmation and physical inspection of the patient's mouth by 2 nurses, ensuring any prosthetic or cosmetic work is logged before the anesthetist arrives. This step is non-negotiable for avoiding further delays.
Question 26. You hear 2 nurses discussing a patient, Mrs. Jenkins, during a shift handover. Now look at the question.
Mrs. Jenkins in 3B, post-cardiac catheterization. She's stable, vital signs normal. She's due for discharge this afternoon, but there's a small issue with medication. The doctor wrote a prescription for warfarin, but the discharge summary currently states aspirin due to a transcription error yesterday. I've flagged it, and the doctor is coming back at 11 a.m. to correct the paperwork. Her husband is insisting she gets the warfarin before leaving, which is correct, so make sure that is signed off and dispensed before she goes. The error needs fixing first.
Got it. Fix the aspirin-warfarin error before discharge.
Question 27. You hear a pharmacist advising a patient about a new liquid iron supplement. Now read the question.
This liquid iron supplement can cause minor constipation, which is common. We can manage that with increased fiber. The crucial thing you need to know is about absorption. You must avoid taking this iron at the same time as dairy products, like milk or cheese, as the calcium drastically reduces its uptake. Conversely, taking it with vitamin C, like a glass of orange juice, will maximize the absorption. So remember to separate it from dairy by at least 2 hours. Also, don't worry if your stool looks dark. That's normal.
Question 28. You hear a consultant dictating notes following a patient review for recurrent lower leg ulcers. Now read the question.
Patient is Mr. Davies, 68, presenting with recurrent venous ulcers. His current primary limiting factor isn't the wound healing itself, which is progressing slowly but steadily. It's the poor compliance with compression bandaging due to the reported discomfort. He claims he removes them every evening. We've ruled out arterial disease. I've instructed the community nurse to switch the current 2-layer bandage to the 4-layer system, as it provides better graduated pressure. I believe the compliance issue is rooted in the current bandage type, not the pain. The goal is to maximize pressure gradient, not comfort.
Question 29. You hear a specialist addressing medical students about interpreting initial findings in suspected deep vein thrombosis, DVT. Now read the question.
When evaluating a patient for a suspected DVT, remember the Wells score is your starting point. Now, while a positive D-dimer blood test is highly sensitive, meaning it's excellent at ruling out DVT, a positive result is not conclusive. It can be raised by infection, surgery, or inflammation. Conversely, the single most reliable clinical indicator we have isn't the score. It is the presence of unilateral lower limb swelling, specifically a difference of 3 centimeters or more between the limbs, which requires immediate Doppler ultrasound confirmation.
Question 30. A nurse is advising a patient, Mrs. Chan, about preparing for an upcoming colonoscopy. Now read the question.
Mrs. Chan, your colonoscopy is scheduled for Friday. The most important part is the prep. Starting tomorrow morning, you must only consume clear liquids. No solid food until after the procedure. You'll take the first dose of the bowel preparation solution tomorrow evening at 6 p.m. and the second dose early Friday morning. Crucially, the doctor emphasized that you must stop taking your iron tablets immediately. They will interfere with the visualization. You can continue taking your blood pressure medication as normal.
So, no solid food from tomorrow morning and stop the iron?
Exactly. Stop the iron and switch to clear liquids from the morning.
Got it.
Part C. Excerpt 1. You will hear an excerpt from a medical lecture given by a geriatric pharmacology consultant, Dr. Helen Quinn, discussing the dangers and management of polypharmacy. You now have 90 seconds to look at the questions.
Good morning. The topic of polypharmacy, the use of 4 or more medications, is critical in geriatric care. This issue is escalating, not simply because people are living longer, but largely because patients are seeing more specialized physicians for specific conditions, meaning they are consulting with a variety of independent specialists who may not be fully aware of the full spectrum of prescriptions issued by others. A major challenge in intervention is poor patient self-reporting. It's difficult to manage what you don't know about. Seniors often cannot distinguish between their various pills, or they may be consuming over-the-counter drugs or herbal supplements. This lack of a comprehensive, updated list of all medications they consume is a significant barrier to safe care. The danger is heightened by physiological changes. The elderly are at higher risk of adverse drug reactions, mainly because of age-related changes in drug excretion. Specifically, there is a reduced rate of drug clearance by the kidneys, which causes certain medications to stay in the system longer at toxic levels. The consequence of this can be subtle but severe. While drug-drug interactions and confusion are common, the most dangerous consequence is the physical risk. The additive effect of multiple sedative or antihypertensive medications often leads to dizziness, gait instability, and consequently unexplained falls and subsequent severe physical injuries. That is the outcome we fear most. To start addressing this, we recommend the brown bag review. We ask the patient to bring every bottle of every pill they possess into the clinic. This is effective not just for inventory, it immediately helps the clinician identify duplicate prescriptions issued by different doctors for the same indication, which is an alarmingly common error. In the long term, communication is essential, but the most proactive approach is deprescribing. We can't simply stop everything at once. The most effective approach is to implement a structured, gradual process of deprescribing unnecessary agents, carefully tapering down or discontinuing one drug at a time while monitoring the patient closely. This requires careful collaboration but yields the best long-term results.
Extract 2. You will hear an excerpt from a health podcast featuring an interview with Dr. Liam Kelly, a physiotherapist specializing in long-term rehabilitation, discussing effective strategies for managing chronic fatigue syndrome, CFS, /myalgic encephalomyelitis, ME. You now have 90 seconds to look at the questions.
Dr. Kelly, thank you for joining us. When we talk about chronic fatigue syndrome, what is the most common reason patients fail to gain consistent control over their symptoms?
The biggest pitfall is the ingrained cultural idea that you must push through an illness. Patients often try to regain fitness or normality through sheer willpower and intensive exercise. But with CFS, ME, this approach is disastrous. This leads directly to post-exertional malaise. PEM, which is not normal fatigue, it's a massive symptom crash that can last for days. That is the main reason for repeated setbacks.
So if pushing through doesn't work, what is the foundational principle for effective management?
The foundational principle is pacing. This means carefully matching daily activity to current energy limitations. It's about budgeting your energy. On a good day, you mustn't overdo it, and on a bad day, you mustn't underdo it. Consistency is key, and it all starts with accurate self-assessment.
How should patients monitor that daily activity budget? Should they just track minutes of exercise?
Simple tracking often misses the point. We ask patients to monitor not just physical effort, but also cognitive strain. Tasks like reading complex documents, attending meetings, or managing finances. These are massive energy sinks for a CFS patient. Therefore, patients should prioritize recording the mental or cognitive effort required for specific tasks, as that often triggers PEM just as severely as physical exertion.
You mentioned the boom and bust cycle. How does that typically start?
The cycle is devastating. It starts when a patient experiences a day or two of feeling slightly better, maybe 50% energy. They misinterpret this brief period of feeling well as having recovered significantly. They boom by doing everything they missed, cleaning, socializing, catching up on work, and then they bust, crashing into a severe PEM flare-up that sets them back for weeks.
And what is your stance on traditional, moderate to high-intensity aerobic exercise?
We are very cautious. Traditional regimens, like those prescribed for cardiovascular health, are designed to intentionally push the body past its current physiological threshold to force adaptation and increase fitness. For CFS-ME patients, that action is precisely what triggers PEM. Our exercise must be strictly low intensity, focused on maintaining current function, not trying to achieve traditional aerobic gains.
So, Dr. Kelly, if we had to summarize the ultimate goal of your intervention as a physiotherapist.
The goal is not to cure the patient. That's beyond our scope. It's to train the patient to independently control their condition through pacing skills. If they can understand their energy envelope and make informed choices to prevent PEM, they minimize the severity and frequency of their crashes, leading to a huge improvement in their quality of life.